Today we are going to be talking about intellectual disability, or what's also known as intellectual developmental disorder. And I sometimes get tripped up on this because this was a diagnosis that was changed in DSM-5. So up through DSM-4-TR, this was known as mental retardation. And if you're cringing a little as I said that, as I just cringed a little when I said that, it's because that's a term that has really fallen out of favor because of lots of negative connotations with the term mental retardation. But at its root, it actually makes really good sense to describe intellectual disability because, of course, when we think of the word retardation today, we tend to think of it in not so pleasant ways and more of an insult, but it actually comes from the French, from the word retard, which means slow or late. So when we're talking about mental retardation, we're actually talking about people who are a little bit slower or later to develop and who do have what we now call intellectual disability. But this was probably about 10, maybe even 15 years ago. There was a real push to change it because of the negative connotations for mental retardation and to give it a different name. But I still sometimes trip up because I'm like, wait, ID, what, wait, what? Because in my head it's MR is how I always just acronym it. But we are going to be talking about intellectual disability and intellectual developmental disorder today in this video. Now, before you go any further, what I'd like you to do is read two articles. Normally in class, I would open with having you read these two articles. They're actually quite short before you panic. One is a double-sided page from a magazine. The other is a double-sided page from a magazine. So really not too labor-intensive here. But I always like to start with these just to give you some perspective. Of course, as we talk about a lot of these different disorders throughout the term, we sometimes have familiarity with some of them. Certainly when we talk about anxiety, everybody watching this video has experienced anxiety at some point. When we talk about depression, some of you will have either dealt with depression yourselves or had loved ones who've dealt with it. When we talk about substance use, you're university students, I'm not kidding myself, you have used substances before. You might not have a substance use disorder. I hope you don't have a substance use disorder, but there's a very good chance you have used a substance before. So there's some degree of familiarity. When we're talking about intellectual disability, it's a little bit different because it's something that's often at an arm's length from us. Some of you, of course, will work with people with intellectual disability and other developmental disorders over the course of your career, or even are doing so already. But others of you have limited experience with it. And so it becomes really challenging to think about, like, what would a life look like with intellectual disability? Because we talk about all these things, and we'll talk about later today some of these different aspects. And one of the things that comes up a lot is centered around Down syndrome. Down syndrome is one of the few disorders that we can screen for when a woman is pregnant and that we know leads to intellectual disability. And so, of course, what the next step that comes sort of naturally from that is, well, it's a disability, it's a chromosomal abnormality. We can screen for it when women are pregnant. So does that mean that we're trying to end intellectual disability by encouraging women to terminate pregnancies if they screen positive? And that's a whole other box that I'm not going to get into just yet. But these two articles are going to touch on that. One is a family, the first one, which is the one from Time magazine, which you will have to access through Google Drive. It's quite an old article. It's from 2005. I don't even know if you guys were alive in 2005, but probably not reading Time magazine. Whereas I was actually teaching this course for the first time in 2005, read this magazine article and thought, ooh, I'm going to integrate that into my class. I've been doing this a long time, guys. And then the other one is from Chatelaine, and it is about a woman who did choose to terminate pregnancy. And this is a little more recent. This was from 2014, so yay for a little more currency. But the Time article is about a family that did not know. It was before screening was available, and they talk about their experience of having a child with intellectual disability. So again, remember that this first article was published at the time that we still used mental retardation as the way to describe intellectual disability today. Second one, more recent, but it gives you two perspectives, and that's what I'm going to want to open our discussion with when we meet in our discussion groups later this week. So have a quick read of those. When you're done, come back to the video. Okay, so you're back. And what's kind of funny to me, of course, is I'm like looking at my notes from when I last taught this in the classroom, and it's like maximum of 25 minutes because of all the other things coming up. But hey, you have unlimited time. Time has no meaning. We're living in a pandemic. Good times. We'll see how long or short this becomes. That was just your warning. So prior to DSM-5, intellectual disability was referred to as mental retardation. You might remember that I've told you before that I sometimes get far ahead of my notes because I don't look at my notes that much, so that just happened. I gave you the whole little spiel about mental retardation, kind of as a preview, but now we can just keep moving. So intellectual disability is defined, or it's characterized by significant limitations in mental abilities that result in impairments in adaptive functioning, such as conceptual, social, and practical skills needed to fulfill aspects of everyday life. Okay, so there's a couple of really important components when we look at this. The first one that we tend to focus on a lot is that adaptive functioning. So we're not just flat out saying something like people with intellectual disability are not intelligent or lack intellect. We're not saying that at all. What we're saying is they have trouble doing the things that the rest of us do every day. So again, in class, this would be a point where I would ask you about some of those activities of daily living. However, number one, I can't get feedback from you right now, so that makes it tricky. But number two, there's a chance that your answers would actually be quite different today as you're watching this than what they would be in class, because I would ask questions like, did you brush your teeth today? And right now, that answer might be no for some of you. I will voluntarily say I did. I'm going to hope that Ian did. Ian is filming today, so we have a different person doing the filming. But that's something that most of us do and we don't really think about. Like, I don't wake up in the morning and think, what do I have to do to get myself ready? I might think about, what do I have to do today, right? So I have to get my child up, get her ready for school, pack her lunch, drop her off, pack myself a lunch because I'm actually coming to campus, which is pretty rare these days. I need coffee, definitely need coffee, but I don't think, I have to brush my teeth, right? That's just sort of an automatic. That's part of me getting up and getting out the door, is taking a shower, brushing my teeth, putting on clothes, right? So you'll remember first day of class, and on Blackboard I reminded you that you do actually need to be clothed when you show up for class, for discussion groups. But today, have you made your bed yet? Possibly not. Again, something that a lot of us do without really thinking about it. Someone with intellectual disability might not remember that they have to make their bed, or think that they have to make their bed, or remember if they've brushed their teeth, or even remember how to brush their teeth. They might have a parent or a caregiver say, go brush your teeth, and they pick up the toothbrush and they brush their teeth, but they've forgotten to wet it and they've forgotten to put toothpaste on. It's still going to be better than not brushing at all, but it's not going to do the job it's intended to do. So what we're really looking at when we're talking about intellectual disability is not a lack of intelligence. We're saying that people have trouble, and what we're looking at to make the diagnosis and determine severity is how much help they need in that everyday living adaptive functioning. Okay? So the three essential elements, so the intellectual limitation, and in the former diagnosis, so in DSM-4-TR, DSM-4, DSM-3R, DSM-3, and so on, there was a strict IQ cutoff. And when we think about IQ, we think about the intelligence quotient. We know that all of the tests of intelligence are standardized around a mean score of 100 with a standard deviation of 15. So this is why you have to take stats and research methods before taking these classes. So when I say stuff like that, you're like, oh yeah, I know that. And normally in class, I would draw a normal curve right now, and then I'd throw 2 lines on it and say, okay, so between plus and minus 1 standard deviation, we have 68% of our population, according to a normal curve. So that means that people with IQ scores from 85 up to 115, so remember, standardized mean of 100, standard deviation of 15. So between 85 and 115, 68% of the population and that's considered normal. Okay, so most of you watching this have an IQ score somewhere between 85 and 115. Then we go one more standard deviation out. And so that takes us to 70 on the low end and 130 on the high end. So when we're getting to more than 2 standard deviations away from the mean, now we're heading into the territory of people who are considered gifted, right? People who have a higher than normal IQ score, and they're considered gifted. On the low end of the spectrum, that's where we start getting into intellectual disability, people who have IQ scores lower than 70. But there's a problem with that. Of course there's a problem with it, or I wouldn't be talking about it. The problem is IQ tests are really centered around things that we typically would be learning in school. So a lot of the questions have to do with school learning, which for someone with intellectual disability, they may not be in school, they may not be successful in school, they may be going to school and just not learning anything. And then there are other components that also, things like pattern making, which you don't need to go to school for, but having practice with different shapes and putting things together, the more you practice it, the easier it is to do. So people with intellectual disability are often scoring lower on IQ tests, but sometimes you have someone who, whether they have gone to a school that has provided them with lots and lots of assistance, whether they have parents or siblings or tutors or whoever in their life really working with them, might actually score above a 70 on an IQ test. But they have those problems with adaptive functioning, okay? So this second piece, this deficits in adaptive skills, is really critical to the diagnosis. And what they've done in DSM-5 is they've taken away the strict IQ score. So it no longer is an IQ score of less than 70 to allow that somebody might get a 75 on the IQ test. But if they can't remember to put toothpaste on their toothbrush before brushing their teeth, we have another problem there. So we look at this deficit in adaptive skills as being somewhat more important. The intelligence score portion is there, but it's not as strict. Higher emphasis on deficits in adaptive skills, and the other component is this early onset. People get traumatic brain injuries all the time. And if you're currently, so you're probably your 4th year student, so I'm going to guess most of you are in your 20s, some of you might be in your 30s, 40s, 50s, whatever, it's all good, right? Education later in life is a wonderful thing. If you were to go skiing this winter, when the ski hills will hopefully open back up, and we will gloriously have the chance to get out and enjoy nature, and you decide that you don't need to wear a helmet, and you know what you're doing, but you do not know what you're doing, and you really should be wearing a helmet, and you ski yourself right into a pole and end up with a traumatic brain injury. Please don't go and do that, by the way. I'm not making suggestions for how to live your best life here. You might then score quite poorly on an intelligence test because you now have brain damage. That does not mean you have an intellectual disability. What we're talking about here is typically is seen before the age of 18. Again, we don't have a strict age by when it must be present because we account for different things that could happen. Children who are homeschooled, let's say, right? So parents aren't reporting that there's a problem, and then they get out of school or they try to take a high school graduation exam and something happens. But typically, we see this when children are young. We might only see it become more apparent when they are starting school, whether it's a preschool program, kindergarten, or grade school. But it has this early onset. A traumatic brain injury or an illness that causes a brain injury. So one of the reasons that most of us, hopefully, have been vaccinated against some common illnesses are things like with something like measles, if you contract it, you can get quite ill. And you could actually essentially kind of, these are not the technical terms that Karen or Ev would be using, but you can kind of fry your brain with a really high fever and cause some brain damage. So that's one of the reasons we want to not have illnesses like that. And so you could, again, have brain damage. You could have a brain tumor. That is not intellectual disability. You could, again, do something silly. An episode of The Simpsons where Homer shoves a crayon right up there into his brain, right? So there are, don't do that either. There are things you can do that would result in a loss of intelligence and scoring poorly on an intelligence test that are not necessarily intellectual disability. That early onset is also a critical part of the definition. Okay, so some of the features, and once again, I've pretty much gotten ahead of myself here. So this is a little repetitive again, but if you want to look at the diagnostic criteria in the textbook, that's where it lays out the DSM criteria for you. Table 5.2, it's page 131 in the 6th edition, page 130 in the 7th edition. And again, throughout a lot of these lectures, I'll reference both. I am teaching from the 7th edition, but I am aware that many of you bought used books of the 6th edition. So I will try to give you the page numbers when possible. So the deficits in intellectual functions, deficits in adaptive functioning, onset during the developmental period. And then what we're doing is determining the severity level. And this is where things get the trickiest, okay? So 85% of people with intellectual disabilities will have what are considered mild intellectual disabilities. So when we think about Chris, okay, so Chris was the child who we read about in the Down Dilemma, that first article from Time magazine. When we think about Chris, he most likely has what is considered a mild intellectual disability. He works, he has a job, he can do some activities of daily living on his own, but he's still not as fully autonomous or as fully developed as a neurotypical adult would be, okay? So people with mild intellectual disability will require some level of support, but not necessarily a ton. So they'll need help in school. They might not be able to achieve a university degree, for example, but they will be able to work and be employable. And actually, some of you may be aware, but may not be aware, here at Mount Royal, we actually have a program, the Transitional Vocational Program, for people with intellectual disabilities and other developmental disorders to help them learn some of the skills that they would need to be employable. And we have pretty good success with employment records for people who've gone through the TVP program. So those are most likely people who would meet mild severity, okay? And the vast majority of people with intellectual disability have a mild severity. About 10% are moderate, 4% severe, 2% profound. When we get into that profound level, these are often people who are nonverbal, who often will essentially be in an infantile state throughout their life. So they will never be able to be out of diapers. They will never be able to indicate when they have to go to the bathroom. They need to be fed. They can't eat on their own. So high level of care, most likely institutionalized, unless parents have tremendous means to afford 24-hour home care and support. So those kind of make sense. They're clear enough. And you're thinking, so Carrie, where's the problem? Like, why is this such a significant issue? Well, the issue is we don't know what severity level someone's going to be until they're actually living their life. So when we go back and think about those two articles that you read, and we think about this issue of if you knew that you were pregnant with a child who had Down syndrome, there's a very good chance that they will have a mild case of intellectual disability. There's a very good chance that they will be like Chris. But are you willing to take the risk that they have a more severe form? And that's the dilemma that's thrown at highly emotional, full of hormones women, and usually you have about a week to decide from when you find out till when you have to make a decision. So no stress there whatsoever, right? We will talk later at different points in the term that the effect stress during pregnancy can have on the developing fetus. But hey, no problem there. So that's where this becomes such a contentious issue and where it becomes so important to be thoughtful. Because yes, most people will have mild intellectual disability, but not all. Okay, now that I've gone dark, let's see where we can go next. I go dark a lot. You guys know that already. Okay, So, of course, in addition to the intellectual disability, we will also find some other things that may come up. So one of the things that we might see happening are some emotional and behavioral problems. So again, having an intellectual disability does not preclude someone from having other struggles as well. And I'm just going to do a little coffee, because otherwise I'll start struggling as well, and that's no fun for anybody. So what we can see is some of the internalizing problems, and again, we've talked about internalizing problems before. We've talked about these are things like depression, anxiety, so those problems where we focus inward. And particularly in adolescence, we may see someone with intellectual disability starting to experience more symptoms of depression and possibly even clinical level depression. Because in adolescence is when it becomes patently clear that there are things that their friends can do that they cannot. In early childhood, in the early years in school, everybody's functioning at different levels, and nobody can go to the movies without their parent driving them there. Nobody can go shopping with their friends without their parents, right? I mean, how many times did you go do that in second grade? Or grade 2? I forget which is Canadian, which is American. I go back and forth between, I think second grade is American, grade 2 is Canadian. It happens. So in adolescence though, as adolescents start forming friend groups that may also lead into romantic relationships, we start seeing differences. When people are getting their driver's license or their learner's permit, we start seeing differences, and this is when it becomes clear to someone, even with a mild level of intellectual disability, that the gulf between what they can do and what neurotypical adolescents can do starts to widen. So that can lead to some depression. We also can see ADHD-related symptoms. So we see some of the behaviors that we would see in ADHD, some of the fidgeting, some of the restlessness, some of the inability to wait, so calling out answers, the distractibility, right? Some of the hyperactivity as well. So we might see that happening. And again, we want to be careful because someone with intellectual disability could also have a comorbid diagnosis of ADHD, but they might just be showing signs of ADHD that are actually more directly linked to the intellectual disability. So diagnosing those things becomes a little bit nuanced. And then some other symptoms as well. Things like self-injurious behavior. See, I was about to be like, wait, what? No, there's the point. So that head banging that we often see with autism spectrum, we see some of that self-stimulation that can happen. They can also do like what's called excoriation, which is skin picking, as well as eye gouging. So like poking themselves in the eye. Yeah, so stuff, Ian just made a face like, what? I was okay with the skin picking, the eye gouging, that was going a step too far. But those are some of the things that we might see. And because I just looked at my notes, I see that I did as well make a note that with the ADHD-related symptoms, that difficulty staying on task is one that we'll see a lot. And we do see some success using the medications that are used to treat ADHD. But again, we have to consider the bigger spectrum of everything that's going on for that person. Yeah, we just heard a weird noise. You heard it too. It is what it is. Okay. Okay, did that. Okay, just making sure. Other physical and health disabilities that we can see happening, certainly people with intellectual disability often have more chronic health issues. Remember that, well, you don't remember this yet because we haven't gotten there yet, but if you read your textbook, we haven't been doing this long enough to know that the answer to that is no, but if you read your textbook, you would have read about the causes of intellectual disability. That's where we're going to go next, that a lot of times it comes down to genetics, it's chromosomal abnormalities, or it's exposure to toxins in utero. So those are things that we would expect would affect more than one system. So it's not just the intellect and the intellectual ability that's affected, but other things as well. So we might see some more chronic health issues as a result, particularly things like epilepsy and cerebral palsy. Interestingly, people with Down syndrome, so this is for Down syndrome specifically, not all forms of intellectual disability, who live past the age of 40 often develop Alzheimer's disease. So here you are, you've overcome so many challenges in your life, you've outlived your life expectancy, and now here's Alzheimer's. It's not fair. But that again speaks to likely some sort of genetic component and some sort of brain abnormality that's underlying everything. We're getting better at studying these things, studying brain structure, brain function, different genetic abnormalities, but we still don't quite have it. So we see this correlation. We know that it tends to happen, that people with Down syndrome do tend to develop Alzheimer's at a higher rate than the general population if they live past 40, but we don't know exactly why. Okay, on to causes. Normally this would be a point where I would say, any questions? So Ian, any questions? Now you're good? Okay, perfect. So let's move on, okay? For many cases of intellectual disability, the cause is unknown. And so that's another piece. So I've been sort of like coming back to this idea that we do, particularly with Down syndrome, we do this screening test when women are pregnant, and they have a choice then whether to continue their pregnancy or terminate it. And I want to also be clear that I am not an advocate for either position. I think every family and every woman ultimately has to make the choice that's best for her. Some people have said, well, if I would plan on having the child regardless, whether they had Down syndrome or not, why should I be screened? And to which I say that's a really valid point. However, what we know is that a child with Down syndrome is going to require more supports and have different needs than a neurotypical child right from infancy. So wouldn't you like to know and get those supports lined up? I can tell you, the immediate postpartum period, when you suddenly have this human life outside of you that you're responsible for, is not the time you want to be searching down government websites looking for grants and for funding for the special care your child might need. So part of it is a preparedness thing, right? Being able to be ready for the child that you're going to have and what their needs might be. So it's not that screening for Down syndrome is a direct line to terminating pregnancies. It's really so that people are more informed about what is going to happen next. But a lot of times, we don't know. If the cause isn't Down syndrome, we don't have any other screening prior to birth that could give us a clue, with the exception of ultrasound might determine a brain abnormality that is either not compatible with life outside of the womb, or that would likely lead to a severe form of intellectual disability, okay? So we do know for some there are genetic and constitutional factors, chromosome abnormalities. So chromosomal abnormalities are responsible for Down syndrome, Klinefelter syndrome, Turner syndrome, Fragile X syndrome, Prader-Willi syndrome, and Angelman syndrome. Lots of different syndromes, okay? Down syndrome is also known as trisomy 21, so there's an extra chromosome on the 21st pair. Klinefelter is when this affects males only. It's when they have an extra X chromosome. So typically, females have two X's, males have an X and a Y. In Klinefelter's, males have an extra X, so they're double XY, okay? Turner syndrome is for females, and that's when they're missing an X. So they only have one X. So they're XO, and there shouldn't be an O. This isn't tic-tac-toe, right? There's X's and Y's, but in Turner, there's only one X in girls, and so that second one is missing. Fragile X, lots of talks of X's right now. Fragile X syndrome is an inherited disorder. Males tend to suffer more from it because they only have one X. So again, normally in class, if you needed an illustration of this, I would draw with chalk an X, right? Like a solid X. And that's what most people have. Women have two, men have one. A fragile X is like a shaky line X. So there's like a little bit of damage, but it's not like specific to one little area that we can pinpoint. But the reason males are going to be more affected by Fragile X syndrome is because they only have one X chromosome. Women have that second X that can compensate for some fragility on one, right? So I'm trying to think of an analogy. If you sort of think about Cinderella and her glass slippers, okay? When she was wearing both of them before she left the ball, she was perfectly steady on her feet, she was fine. But when one fell off, she goes tripping down the stairs. That's kind of the idea here. That fragile X for females is like the glass slipper that has fallen off. She could still walk. She still made it to the carriage before it turned into a pumpkin, but it was with difficulty. Whereas with two glass slippers on, she could dance and twirl and charm the prince, who would then come looking for her. Okay? Men can't walk in glass slippers. They can't walk in high heels. It's very challenging for them. So if they have only part of a glass slipper, they're just tripping all over the place. And that's sort of why the fragile X is going to affect males more than females. I hope that analogy made sense. Ian, did that kind of make sense? It kind of worked? Yeah, that was a new one I just pulled out of my back pocket. You never know what you're going to get with me. It's kind of fun. Unpredictable. Okay, Prader-Willi syndrome is also a genetic diagnosis, and this Prader-Willi is typified by an abnormal or an involuntary urge to eat constantly. So that is sort of the hallmark, but we do see that people with Prader-Willi also tend to have intellectual disability. Often they have learning disabilities. They tend to be shorter in stature with low muscle tone and also incomplete sexual development. There's a whole lot going on with Prader-Willi, and that is an abnormality on the 15th chromosome pair. And then finally, Angelman syndrome is typically moderate to severe intellectual disability, as well as some movement symptoms and an absence of speech. So Down syndrome is the one that we can screen for ahead of time. There's a host of other things that can also, due to chromosomal abnormalities, lead to intellectual disability. Then we also have single gene conditions, and the most fun one to say is phenylketonuria, which is why most people just refer to it as PKU. PKU is, so having phenylketonuria it's a recessive gene disorder, and basically the person lacks certain enzymes to break down phenylalanine into tyrosine, and both of those are amino acids. So basically you're just missing something to break down the amino acid, and tyrosine is needed for physical development. Now here's the good news about PKU, because there is good news for this one. Babies are tested for PKU pretty much right after birth, within their first 24 hours of life. They're actually, at least here in Alberta, there's a whole metabolic panel that they're tested for. They take a little prick of blood from their heel, they send it off to the lab, because if someone has phenylketonuria, you can actually mitigate against it or protect against it by changing the person's diet, by making sure they're not eating foods that have a lot of phenylalanine in it. Because if you can't process phenylalanine, you don't want to consume phenylalanine, right? So that's a really important one. The problem is if people decline testing at birth. Now in Alberta, I don't even remember consenting to it when I had my daughter, to be quite honest. They came in, they took her blood, she screamed, I held her, it was fine. But what's interesting is because I had already been teaching this course and because I had knowledge of this, I was like, I know that they're screening her for PKU. Nobody ever gave me test results, which usually the no news is good news is quite true. But I remember when my daughter was probably about 2 weeks old and we were at an appointment with our family doctor, I said, so like, is there any info from the metabolic screen? She's like, oh, yeah, let me look that up. She's like, oh yeah, everything's fine. She's like, you probably would have heard by now if there was a problem. And I'm like, I don't like the probably in that statement, right? Because I know that if, for example, my daughter had phenylketonuria and she was being fed that, I mean, at that point it was formula, a mix of formula and breast milk, but we would have to be using a special formula and I'd have to be reducing the phenylalanine in my diet to make sure that she wasn't getting any, right? So that's really important to know. If people decline testing in countries or in states or provinces where testing isn't mandatory upon birth, if someone gives birth in the bathroom and is trying to hide the pregnancy from their parents, and the child has PKU and is not given a corrective diet, then that can turn into intellectual disability. So Freud wasn't always right when he said blame the mother, but that's one where, if you don't get your kid tested, maybe a little bit. I don't usually agree with Papa Freud on much, so that's kind of a rarity. Okay, we have other neurobiological factors at play as well, things like exposure to toxic substances, adverse biological conditions, prenatal and perinatal stressors can be a factor as well. So I had mentioned this earlier, that toxicity in utero and also stress can be a factor as well. When we're talking about as well some of these adverse biological conditions, we're talking about some of the illnesses that a mother can contract when she's pregnant. And of course, if a woman has been drinking during pregnancy, which is the other big sort of controversial, gets a lot of attention debate, the child can be born with fetal alcohol spectrum disorder, and typically children with fetal alcohol spectrum disorder will have intellectual disability. It could be quite mild. They could have a host of other problems. The reason this becomes debatable, and we'll probably end up talking about it in our discussion groups a little bit, is because at this point, we know that the only safe level of alcohol use during pregnancy is 0. The reason we know that that's the only safe level is because we cannot do tests on pregnant women, right? Think about it for a moment. And I know that not all of you in the class are female, so imagine if you had a female partner or a female loved one, because maybe you aren't going to have a female partner, and that's perfectly okay. But a sister, a parent, a really close friend who's pregnant and says to you, hey, you're a psych major and you just took that atypical child development class. How much can I drink during pregnancy? And you're like, nothing. They're like, but women in France and women in Argentina, wine-producing countries, tend to drink a lot during pregnancy, and they don't have a higher rate of fetal alcohol syndrome than we have in North America. So why does North America have a stick up their bum about this and say, pregnant women, thou shalt not drink, and if you do, we shall shame you mercilessly? The reason is we don't know what the safe limit is. So the best advice we can give is the only safe limit is none whatsoever, because we cannot take a bunch of pregnant women and enroll them in a study where they will either get a placebo, they will get 1 alcoholic drink a week, 1 alcoholic drink a day, or 4 alcoholic weeks a day, and then wait 9 months and see what happens to their baby to determine what a safe level of alcohol is. So because we can't do that, and because people, particularly if they're drinking a lot during pregnancy, they're not going to be the most accurate self-reporters. So we can't go just based on self-report. We can't say to women, keep a journal of how much you drink during your pregnancy. I mean, think about yourselves. Would you be honest if I asked you to keep a drinking journal for a week? Right, there's your answer. So we say don't, because fetal alcohol spectrum disorder, we know can be a result, okay? And then also we have social and psychological dimensions. Oh, and it's just barely not getting cut off. Perfect. So things like deprivation and other mental illnesses. Babies don't need a lot, right? You would be surprised at how little babies actually need based on what they try to make you believe babies need when they're born. But at the end of the day, babies need diapers, some clothes. You want to keep them warm. They have trouble regulating their temperature at first. They need to be fed, and they need to be loved. That's pretty much it. Now, if you just do that, the child will survive. Will they thrive? Not as sure. Things like reading to a child, things like singing to a child, those are things that enrich the child's experience. When the baby is old enough to start eating food, giving them a variety of different foods will enhance their experience. So we can see things like deprivation, where a child, an infant, is sat in front of a TV all day with very little human interaction. So they are fed, they are clothed, you know, their basic needs are met, but some of that other stuff isn't being met. We can see intellectual disability, right? So that's some of what we think about. And we see that sometimes, particularly with poverty. We see people sometimes doing things like formula when you buy a can of formula, it has a very specific formula for how to make it, right? So it's this many scoops, level scoops, not extra, not under, and this much water precisely. And some people will use double the amount of water to make it last longer, but what they're actually doing is depriving their child of some of the nutrients that they need for optimal brain development. In a perfect world, we would actually provide people with what they needed to care for their child. It's not that radical an idea, right? Formula is wildly expensive as well, which is why we often see that happening for people who are living in poverty. So that, unfortunately, though, can lead to intellectual disability. And then, of course, other mental illnesses, both on the part of the child, because we all are born with genetic code that can predispose us to different things, but also on the part of the parent. If the parent really isn't able to care for the child properly because of their own mental illness, that can be a factor in leading to intellectual disability. Now, I have a sticky note here that says there's a reflection question coming up. And here is reflection question number 1. So after you read this question, pause the video, answer it, and then come on back. Given that many causes of intellectual disability are either unknown or due to a genetic defect, why do you think some people look down on people with intellectual disability or blame the parents for the condition? Remember, 1 paragraph, maximum of 6 sentences. Go. All right, excuse me, welcome back as I hit the mic too. That's fun times. We are now moving on to our second chapter in this lecture. So this was, this week we were covering intellectual disability, and now we're also going to talk very briefly about communication and learning disorders. So what we're going to start with is our 2 short videos. Whoops, I do that sometimes. The first one is about 3.5 minutes, and it's an example of what it's like to have a learning disability. So for this one, before watching it, please make sure you have something to write with, like just a piece of scratch paper. It's nothing that you need to hand in. It's nothing that you need to scan or take a picture and send to me. Just try it. And then the second one is about 10 minutes long, and it's a young adult's describing her experience with a learning disability and what that was like for her, okay? But then the other thing, there's always another thing with me. I highly recommend watching How Difficult Can This Be? The Fat City Workshop. It's 70 minutes, so it's a little bit over an hour. It is streaming from the library website on the Canopy streaming service, and I have verification from our area librarian that that is a title that we have unlimited streaming on. It's also on DVD available from the library if you want to rock it old school. However, at the moment, the library is not circulating material, although they are circulating some materials. You can put in a request and get it. If you are taking Psych 4485 with me this term, so if you're in my advanced abnormal class, and I know there's a couple of you who are, or if you are planning on taking, or you're registered for 4485 with me for winter, don't watch it, because we're going to watch it in that class, okay? I don't believe the other 4485 instructors show it, so if you are taking 4485 with someone else, feel free, have at her. And if you are taking 4485 with me and want to watch it, it's actually okay, but we're going to get to that in a few weeks. We're working at different paces in the different classes. So just to let you know. The other thing is the video is older, so please don't get caught up in mocking the hair and clothing styles. As well, the lead presenter has a very, very thick Boston accent. So some students in the past have found it helpful to put captioning on and be able to read what he's saying because he has a very thick accent. So I'm just going to give you that. But the ones that you need to watch for this class are these 2 YouTube clips. Again, the first one's about 3.5 minutes. Second one is about 10 minutes. Go ahead and watch those and then come on back. Okay, so when we're talking about learning disorders, we're going to start with learning disorders and then get into communication disorders. And I really don't have all that much to say about these. Learning disability is the common term. So you've already heard me use that term. I tend to use the 2 interchangeably. Learning disorder is what you will find in the DSM. The diagnoses in the DSM-5 are communication disorders and learning disorders. So even though we use the term learning disability quite often, what we're actually talking about is a learning disorder or a communication disorder. Learning disability refers to significant problems in mastering one or more of the following skills: listening, speaking, reading, writing, reasoning, or mathematics. Okay? So when we think about those things, those are pretty critical for success in school. And if you are struggling with those, it might make school more difficult. Now, remember how when we talked about intellectual disability, we talked about the normal curve, we talked about the whole plus minus standard deviation thing? Right, we're going to come back to that because a lot of people struggle in school. They do. A lot of people struggle with math. A lot of people struggle with reading and writing. Do they all have learning disabilities or learning disorder? No. To properly diagnose a learning disorder, we have to run a person through some standardized testing as well as getting a learning history and developmental history. And so part of the testing involves administering an intelligence test, so an IQ test, the same type of test we would use with intellectual disability to get a sense of where a person is. And then based on their score on the intelligence test, we can predict how they would do on what's called an achievement test. Achievement test is, again, a standardized test. It has a mean, it has its standard deviation, but it's different, whereas the intelligence test is the same one. If you're an adult, if you are given the WAIS, so the Wechsler Adult Intelligence Scale, when you're 18 and again at 25, it's going to be the same test. You're probably not going to remember it. Because I've administered the test so much, I have the unique problem of there are parts that I remember that, like, even when I'm old and they're testing me for Alzheimer's, I'm going to be able to recite the short story because I've administered the test so many times. But for most of you, that won't be a problem. The stories are pretty benign. You're not going to remember it. With the achievement test, we score it differently based on a person's age and grade level. And so based on their age, grade level, and their intelligence quotient, so their score on the intelligence test, we can predict the range of scores for the achievement test. If someone is, again, here's the standard deviation thing, significantly below what is expected, then we diagnose a learning disorder. So simply struggling in school does not mean you have a learning disorder. You have to be struggling a lot and be struggling at a point that is significantly lower than what is expected based on your intelligence, your age, and your grade level. So all that gets considered in the mix. Communication disorder is a diagnostic term that refers to deficits in language, speech, and communication. Okay? And then specific learning disorder is a diagnostic term that refers to the specific problems in learning and using academic skills. So you can have a specific learning disorder in reading. You can have a specific learning disorder in mathematics. You can have a specific learning disorder in written expression. Okay, those are the specific learning disorders that we'll see in the DSM. So reflection question number 2. Do you think learning disorders should be classified in the DSM? And remember that the formal name for the DSM is the Diagnostic and Statistical Manual of Mental Disorders. Do you think learning disorders should be considered mental disorders is basically what this question is getting at. Why or why not? Again, remember, 1 paragraph, 6 sentences, go. Okay, and now that you're back, we're going to talk just very briefly about communication disorders because this is really just mainly for your information. It is a factor, of course, for children who have a communication disorder, and that's why we discuss it in atypical child development. However, treating communication disorders is largely the domain of speech-language pathologists and occupational therapists to an extent, not typically psychologists. If there's an anxiety component underlying the speech disorder, then a psychologist might be involved, but typically, when you're having trouble with speech and with communication, you go to a speech-language pathologist first, right? It's kind of like if you have a broken leg, you're not going to go to your dentist. You can go to the emergency room, right? You need an x-ray. You need to be casted. You don't need someone looking at your teeth. So speech-language problems are going to go to a speech-language pathologist as sort of the first line, and then, depending on the severity and what's going on, occupational therapy might be recommended, or a psychology visit might be recommended as well. So language disorder is difficulties in the comprehension or production of spoken or written language. And again, one of the things that we have to keep in mind with that is we have to keep in mind assuming English, because that's the language we're currently working in, is it their first language? So if somebody's having trouble understanding or writing or speaking in English, is it because they're just learning? Right? So you can have a 30-year-old who has grown up in a foreign country and who has never spoken English before, and they come to North America and they struggle with English. It does not mean they have a language disorder. It means they don't know the language. Okay, so we have to be clear on what we're looking at here. Childhood onset fluency disorder is a fancy way of saying stuttering. It's actually more descriptive because that's what's happening, but it's more commonly known as stuttering. And this is repeated and prolonged pronunciation of certain syllables that interferes with communication. And I've included a little web link here. This is just so a grade 3 student who wrote about his experience with stuttering and how challenging it could be. So it's just, again, a quick little, it's like a blog entry, but it might just give you a little bit of a sense of what that's like for a child. And then finally, social pragmatic communication disorder, which is persistent difficulties with pragmatics, which are the social uses of language and communication. So things like conversational norms and body language. And that's something else that we do have to consider certain things, certain societal aspects. So up until March, it wasn't normal to stand 6 feet apart from a friend while talking to them. Now we wouldn't dream of getting closer, right? But a child who prior to March of 2020, prior to the global pandemic of COVID-19, if you had a child who insisted on being 6 feet apart from anybody before talking to them, we would think, what's wrong with that kid, right? That's just not normal. Similarly, and this is where I miss the fact that we're in class, because right now is when I would walk right up to someone sitting there and go, so what about close talkers? We all know some close talkers. We all hate close talkers. Thankfully, with the pandemic, there are no more close talkers, right? It just can't exist. But so that's where we have to consider social norms in determining some of those conversational norms. Also, like, if you ask someone, how's it going? Actually, let me even just demonstrate, Ian, if you don't mind. How's it going? It's going good? Okay. If you were to then ask me a question, what would you say?
How's it going?
Right, because that's the conversational norm, right? So you say to someone, how's it going? Nobody wants to be friends with the person who you're like, how's it going? And they're like, I'm good, let me tell you all about this. And then they go off and you're like, hey, what about me? Right? What about me? Well, the normal thing to do is, how's it going? Good. How's it going for you? That's how we do things. And body language as well. People with social or pragmatic communication disorder have a really hard time reading other people's body language and have a hard time matching their body language to what they're trying to express. Okay, that's really it for communication disorders. We're just going to quickly take a quick look at the specific learning disorder diagnoses, and then that's going to wrap up this video. So again, you can find the DSM-5 criteria, table 7.4, pages 210 to 11 in the 6th edition, 209, 210 in the 7th edition. And as I mentioned before, there are 3, and I'm just putting them all up even though I had my timing all nice and set up, 3 different specific learning disorders. So there's specific learning disorder with impairment in reading, which is where the person lacks the critical language skills required for basic reading, word reading accuracy, reading comprehension, and reading rate or fluency. And this encompasses what we often talk about as dyslexia, right? So people with dyslexia often have difficulty reading the words because they're reversing some of the letters, and same to sometimes with writing as well. We can have a specific learning disorder with impairment in written expression, which manifests as problems in spelling accuracy, grammar, and punctuation accuracy, and or clarity or organization of written expression. This is one that is getting a little more challenging because of the first part, problems in spelling accuracy, grammar, and punctuation accuracy. Because children, adolescents, adults, older adults all now write in text speak. And it's annoying. The letter U is not the word Y-O-U. It's one of the things that really gets me. And especially when like my dad will be like, how are you? And I'm like, just type out the extra two. It doesn't cost any extra. This is not like the era of telex machines where every character cost money. If you send me a text message that's 150 characters or one that's 1,500 characters, you're paying the same thing. Doesn't matter. So when we think about adolescents and children today who are growing up with spell check embedded in their lives, who have cell phones pretty much from the moment they can talk, we're starting to see a lot of difficulties with spelling accuracy, grammar, and especially punctuation accuracy. And let this be the warning to you. When you submit any written work to me, if you are an over comma user, I will not be pleased. Commas have a place, and the Oxford comma especially has a place. However, if every word has a comma after it, you're using too many damn commas. Okay, cut the commas out. I'm curious to see 10 years from now what this diagnosis looks like, whether we're then just focused on the clarity or organization of written expression, because that might be what happens. And then finally, specific learning disorder with impairment in mathematics, difficulties in number sense, memorization of arithmetic facts, accurate or fluent calculation, and or accurate math reasoning. This too, I remember in elementary school when teachers would say things like, when we'd question things in math and be like, do you think, we'd say, why can't we just use a calculator? Do you think when you're an adult, you'll just have a calculator all the time? And I want to go back to those teachers and say, yes, as a matter of fact, I do now. Because my phone has a calculator that I don't even have to unlock my phone to use. I just swipe and boom, there it is. We all have calculators all the time now. I'm sure that the pushback on elementary and possibly even more so high school teachers is extreme when they're like, you have to know how to do it without a calculator. And students are like, why? Calculators are everywhere now, okay? So there might be some changes here, but learning the different rules of mathematics, understanding how to do certain things. There are some people who will have significant impairment in that, and they then have a specific learning disorder with impairment in mathematics. And that wraps up Chapter 7.